Okay, students, this is a quick labor and delivery review. Remember that labor and delivery 101 was covered in OB Sim Lab, so we're not going to go back through all of the nitty gritty. We're just going to hit the highlights for this lecture from chapter 27 in your big book and chapter 10, 11 in your ATI book. So let's jump in. Okay, birth planning. When do we start planning for birth? Well, typically early in the pregnancy. Our moms already have some idea about what kind of labor they want to have, what kind of delivery they want to have, or that they're able to have, right? So if they've had previous C-sections, they may know that they're going to have a C-section. If they'd like a natural approach, they may know that they don't want to try any pain meds or have an epidural. If they want to take an alternative birthing method, they may be looking into water births or different hypnotherapies, etc. So this begins as an outline of the options available for labor, delivery, postpartum periods, and typically with the tour of a unit and getting comfortable with what is to come. So a lot of places moms can choose to deliver, obviously hospitals, that's very traditional, lithotomy position on their back, legs up, right? But hospitals have become a lot more family friendly, a lot more natural birthing friendly. We now have natural birthing centers inside hospitals and also freestanding birthing centers. And then there's always the option to deliver at home, given the correct association with a provider, such as a midwife that's able to come into the home or another provider that's comfortable with home visits or home birth. So this is going to be really important. ATI loves to test on the signs of impending labor. Somebody is going into labor. One of those things that we see is lightning. Now, this is not lightning like thunder and lightning. This is lightening, like getting less heavy. And that's going to help you understand what this type of lightening is. This is where that fetal head moves into the true pelvis about 14 days before labor. And that fetus will have, what do we call that? Dropped, right? Oh, girl, you've dropped. You're about to have that baby, right? It makes for mom to have easier breathing because that diaphragm pressure is not there anymore, but she does have the potential for some incontinence because that baby is now sitting directly on that bladder. So she's going to be more frequent with her urination and may even have some incontinence. Lightning is especially obvious when you have a mom who's a first-time mom, so a prima gravida. Multi-gravidas sometimes carry pretty low because of the stretching of those round ligaments. But those first-time moms, there's definitely a very obvious drop, which is called lightening. The next thing that you might see is seepage. So I don't like this term. This is not a term that ATI uses, so I don't think it's super important for you to know. I would say that seepage is loss of fluids, right? So let's talk first of all about the types of fluids we might see. Obviously, we might see increased vaginal discharge as the cervix begins to ripen and the vagina begins to prepare for delivery. We also may see amniotic fluid loss, right? That's that membranes, the bag of membranes. Should it rupture, we're looking at color, consistency, and amount. So amniotic fluid should be a watery, clear, slightly yellow, but not yellow, green, brown. Yellow, green, brown would indicate that we have meconium in that amniotic fluid, which would be abnormal and concerning for respiratory distress in the newborn. There should not be a foul odor to any type of amniotic fluid leaking, or excuse me, any amniotic fluid leaking from the vagina. It should be a slightly sweet smell, if anything. The volume is usually between 700 and 1,000 milliliters, so it's pretty profound. However, there can be very subtle leaking over a period of time as well. To confirm that it is amniotic fluid, we may use nitrazine paper. Nitrazine paper is deep blue color. So, or excuse me, it's a yellow color and it turns a deep blue color in the presence of amniotic fluid, indicating that you have an alkalinic fluid in contact with that paper. Urine is acidic, so it's not going to cause that nitrazine paper to change, but amniotic fluid is alkalinic, so it will change that nitrazine paper from yellow to blue. Okay, so that's really what seepage is in this case. Is what I'm gonna kind of cut it at. Another thing we might see is bloody show. So there is a ball of mucus that plugs up the cervix so that it decreases risk of infection. It kind of stops up baby like a wine cork, right? Holds baby up in that uterus until it's time for baby to come out. But as that cervix starts to make change and begins to dilate, that mucus plug no longer fits snugly. And so eventually it does come out. So an expulsion of a cervical mucus plug may occur. That mucus plug is usually brown or maybe even slightly blood tinged. So it might have some red or pink blood on it. And it's really thick. And again, it's happening with that cervical dilation and effacement. Contractions certainly are a part of impending labor. Contractions usually start with those irregular practice contractions called Braxton Hicks. And remember, Braxton Hicks typically resolve with rest and water. But true contractions do not resolve with rest and water. They, in fact, continue to get stronger. Eventually, contractions will move from those Braxton Hicks to true contractions that are strong and regular. And when we are 5 minutes apart, we'll say we're definitely moving towards labor. And remember, true labor is contractions that cause cervical change. So if we're not changing that cervix, it doesn't matter how many contractions we're having, we're not in true labor. You may see a slight weight loss in your patients as well. So about a half pound, a pound to about 3.5 pounds. So 1 to 3.5 pound weight loss right before delivery, which is very interesting. We also may see effacement. Effacement, of course, is the thinning of our cervix, right? That allows that cervix to dilate more effectively. The cervix also will become soft as it starts to open, so it can dilate more effectively. Other things that we might see as signs of impending labor and things that you should probably know for ATI are backache, that constant, low, dull backache. And that's from those pelvic muscles really relaxing to allow that baby to get engaged. So if you start having backache towards the end of labor, that may be an indication that, towards the end of pregnancy, that may be an indication that labor is right around the corner. Another thing you might see is an energy burst, right? That nesting response. Moms will start to put everything away and get the nursery tidy and pack the bag. And, I've got all this energy that came out of nowhere, where maybe they have been really tired and lethargic throughout the pregnancy. But now they have a big burst of energy and they're excited for this baby to come. There also may be some gastrointestinal changes due to like the pressure and the contractions, the pain, like nausea, vomiting, upset stomach, indigestion certainly could happen. Just a quick reminder with the rupture of membranes that when it is spontaneous or artificial, we need to make sure that that fluid slowly leaks out, doesn't come out all in one gush. We're really worried about that umbilical cord potentially getting between baby and the cervix and getting pinched off. So we should always check that fetal heart rate for any type of deceleration and to rule out umbilical cord prolapse. And we really don't want that rupture to be prolonged, right? So if they've had ruptured of membranes for greater than 24 hours and they haven't started labor, there's a huge risk to infection. There's a huge risk for serious complications associated with delivery. Okay, so going into true versus false labor. We talked a little bit about this already. True versus false labor. False labor, those contractions are usually pretty irregular. They don't follow a pretty pattern. They vary in how long they are. They maybe are not as strong. Each one is a little bit different. They're always most noticeable at the top of the uterus in the fundus, but they're not typically throughout the entire abdomen, right? So when palpating the lower abdomen, right above the pubic symphysis, we're not feeling those contractions, just in the top of the uterus. They stop when we relax. Again, if we put our feet up, we drink lots of water, those Braxton Hicks will typically go away. And here is the critical point, right? Contractions that cause cervical change is true labor. If there's no effacement or dilation with your contractions, that's considered a false labor or pre-labor. Additionally, that baby is not going to become engaged into the pelvis. With a true labor, we see those regular contractions. That means they're about the same distance apart. They're getting closer together. They're getting stronger. They're lasting longer. When you get up and move around, they get stronger. But when you relax, they don't really stop either. They usually start in the lower back. So that's a little bit different, right, than the top of the fundus. They start in that lower back and they travel around to that lower abdomen, and they certainly can be palpated throughout the entire abdomen. When you drink that water, put your feet up, we're seeing them continue to become stronger and get closer together. And we're going to see that cervical change, right? Those contractions are going to cause the cervix to soften, efface, and dilate, and that baby is going to come down into that pelvis and become truly engaged for delivery. Okay, so when we're talking about the process of labor delivery, we have to assess the 5 Ps. These 5 Ps are very, very important for delivery. So the 5 Ps are the passageway. This is the way that the baby comes out, right? We got to think about the passageway. The pelvis, the soft tissue. Do we have the right shaped pelvis to get this baby delivered? Is our cervix dilating appropriately to be able to pass this baby through, right? We have to assess, is this passageway going to be conducive to the delivery of a fetus? And then you have 2 passengers. People always forget about the second passenger, right? So the first passenger is obviously the fetus, the baby that we're going to be delivering. And then the second passenger is the placenta, because remember, after the delivery of the fetus, we deliver the placenta. And that is that 3rd stage of labor. The powers, we need to assess those. That's our contractions. Are they regular enough? Are they strong enough? Are they causing enough cervical change to continue to progress with the labor? The 4th P is the position of mom. And remember, we're constantly changing position to help baby kind of corkscrew down into that pelvis and get into a position where it's flexed and ready to be delivered. So we might have mom standing, walking, shifting side to side, laying on her side, squatting, on her hands and knees, all different types of positions. We might be using that peanut ball. We might be using an exercise ball. We might get her in the bathtub just to get her positions changed so that that baby can labor down. And then lastly, psyche. How is mom responding to this? What is mom's psychological response to labor? It is totally normal for mom to be stressed, tense, or anxious, but do recognize that those feelings and emotions can hinder labor and delivery. So being really stressed out, being very tense, being very anxious could potentially cause you not to dilate and progress like we'd like to see. So here's an issue that we might have with our passageway, right? This is cephalopelvic disproportion. This is where baby's head is bigger than the outlet or the bottom portion of the pelvis. That is a problem because no matter how much you want to try, you can't fit a square peg through a round hole, right? And a big old baby head or big old baby shoulders is going to cause an issue for delivery. So if the measurement of the baby's head is larger than the measurement of the pelvic outlet, that baby is not progressing past the outlet of the pelvis, we really need to get that mommy back for a C-section because this is just going to stress baby out. We're going to be bunking baby's head up against that pelvic bone over and over and over again with those contractions without any type of progress or change in fetal station. Powers. Okay, so obviously we're assessing the uterine contractions, but also we're assessing our secondary powers. So secondary powers are mom's efforts, her pushing efforts, because we know sometimes moms just do not push well. And the best way for moms to push that we found is for them to really take a big deep breath, and bear down. Remember, we're counting 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Good job, mama. Right back at it. We push 3 times with each contraction as long as baby is tolerating it. If baby isn't tolerating pushing, we may start to push every other contraction or every 3rd contraction. But we got to make sure that mom's pushing efforts and those uterine contractions are effective. Now, remember, our tokodynammeter does not tell us how strong our contractions are. That TOCO is just going to tell us how frequent those contractions are and how long they last. So if we want to know how strong contractions are because we're worried because we're not making progress, we may have to insert an IUPC, an intrauterine pressure catheter, and get our Montevideo units, which are a measurement in millimeters of mercury, how strong those contractions are. Okay, so how do we actually deliver this baby? It's a quite complicated process. And you might not know that if you're the mom in the bed, because you feel like it's just, they come in, they check my cervix and they tell me to push and the baby's here, right? But from the nursing and physician side, it is quite involved. Okay. So baby has to become engaged, obviously. Baby has to descend down into the pelvis and then obviously through the pelvis. Baby needs to internally rotate. And then baby is flexed, remember, but then ultimately will extend. And then you have restitution, external rotation, and eventually expulsion. ATI does not heavily emphasize the mechanisms of labor, so I wouldn't stress about knowing these in detail. ATI cares a lot more about the stages of labor, which we'll talk about momentarily. Here we go. Stages of labor. That first stage is our dilation stage, right? So when you have your onset of regular uterine contractions, that is the start of the first stage of labor. So remember, anything that's not regular is not considered labor. That's pre-labor or false labor. But the first stage of true labor is when you're having those regular contractions producing cervical change. And when you are fully effaced and dilated, so 100% effaced and 10 centimeters dilated, you've officially made it past the first stage of labor. So that is the total first stage of labor, from the onset of regular contractions to full dilation. And that's further broken down into 3 parts, okay? So the first part is the latent phase of labor. The latent or early phase of labor, you need to be getting your mom's blood pressure every half hour to every hour. You need to be getting her temperature every 2 to 4 hours, unless her membranes are broken, right? A little bit more frequently, maybe 1 to 2. You need to be monitoring contractions every half hour to hour. And you need to be doing fetal monitoring at least every half hour to hour as well. In this early stage, we typically have mom moving around a lot, right? Trying to get that cervix to dilate. That latent phase is 1 to 3 centimeters of dilation. So that just really that beginning part. And ATI actually combines, or excuse me, ATI actually does not break these down like your book does. So your book has the latent phase is 1 to 3, the active phase is 4 to 6, and the transitional phase is 7 to 10. ATI, and this is something to note, just has the latent and active phase as the 2 phases of the first stage. So that's something to realize and recognize. In that latent phase, ATI has grouped everything from 0 to 5 centimeters as latent. That's the onset of contractions. They start as irregular, they get regular. They're mild to moderate in their strength, happening every 5 to 30 minutes, lasting 30 to 45 seconds. You may have some discharge, pale pink, mucus, discharge of the mucus plug, some brownish discharge. Mom's typically able to talk through these contractions. She's thinking a lot about labor and the baby that's coming and all those fun things. She can follow direction. She may be a little bit apprehensive or nervous, but she's relatively calm. As you move into that active phase, which ATI combines active and transitional into one phase called active, ATI says that that's 6 centimeters to 10 centimeters with regular, moderate to strong contractions occurring every 3 to 5 minutes and lasting 40 to 90 seconds each. And of course, that active phase lasts until complete dilation at 10 centimeters. Mom becomes very serious, may feel helpless, anxious, apprehensive, really worried about pain at that point, right? It becomes extremely painful. It's hard to think about the outcome. This is when a lot of moms say, I can't do this, right? So when we say, well, you're going to have to, and it's never a pleasant conversation, but eventually they understand that this is just part of the process. The pain may be pretty severe. Mom may even feel out of control or angry or irritable. She may get really sick and start to throw up. That's totally normal. In fact, that's a good sign in labor and delivery. We typically say, oop, that means that we're making some real progress if you start to get sick. She also may feel some rectal pain or the need to have a bowel movement. That's usually just the pressure of that fetus coming down into the vagina, really putting pressure on the surrounding structures. So if your mom ever says, I feel like I need to use the bathroom, you're like, oh, let me check you, because usually that means we've got a baby that's ready to crown or getting close to it. There may be some bloody show here. And then this is obviously the most difficult part of labor, right? Going from 6 to 10 and then getting ready to prepare for delivery. The second stage is the delivery of the fetus. Mom is fully dilated. That's when the second stage starts. And it ends with the birth of the newborn. Okay. That's important to note that it does not end with the birth of the placenta. That's the third stage. It ends with the birth of the fetus. So we're pushing, we're bringing that baby down. And then eventually we have produced the newborn baby in that second stage. So in that second stage, we've got lots of different data collection going on. We're taking the blood pressure, pulse, respirations every 5 minutes or so, every 5 to 30 minutes. She's having contractions. We're pushing. There's lots of, things happening. The partner should be actively involved, encouraging mom, maybe doing some cloths across the forehead, holding a hand, assisting in breathing, or holding a foot. We're positioning the client to make sure that the pushing efforts are effective. We're really encouraging her to rest between contractions. We're getting that fetal heart rate very frequently, every 5 minutes or so. We're checking temperature every 2 to 4 hours. And we're just really, really involved. Typically, when we're in this, 100% of the time, when we're in the second stage of labor, we're bedside. We're not leaving the bed. Just a quick thought, while we're in the first and second stage of labor, remember, if we tested positive for Group B strep at 36 to 37 weeks, we'll be getting IV prophylactic antibiotics. Remember, that's penicillin G. $5 million, I wish, 5 million unit loading dose and a 2.5 million unit follow-up dose every 4 hours until delivery. And if we get 4 hours of that loading dose in prior to delivery, baby is covered. Additionally, when mom comes in and she becomes admitted, we're going to do some Leopold maneuvers to figure out what our presenting part is, how that baby is lying, what its attitude is. We're going to be doing electronic fetal monitoring with our toco transducer and our ultrasound, right? Looking at the contraction patterns so we can really measure that, looking at baby's tolerance of labor, and looking for a reactive strip from baby. Baseline of 110 to 160, moderate variability, accelerations with no decelerations. We also are going to get a urinalysis on mom. We're looking for the specific gravity to see if she's dehydrated, ketones to see if she's had any issues with uncontrolled glucose or potentially dehydration or impaired nutrition. Looking for protein in the urine, which could be indicative of high blood pressure or preeclampsia. Glucose in the urine, which would be indicative of gestational diabetes, or a urinary tract infection, which we know could actually kick you into preterm labor. Additionally, we want to get mom drug tested because if there's a drug on board, we've got huge risk for placental abruption, uterine abruption, and issues with baby and respiratory distress or intolerance of labor. We also want to get mom's CBC to see how her hemoglobin hematocrit is, what her platelets look like, especially if she wants to get a epidural. We want to get her blood type and her RH factor. If she was negative, she should have got a RhoGAM shot at 28 weeks. We'll give her another after she delivers. If she is positive, that's usually irrelevant. But we want to know her blood type just in case we have a hemorrhage. We have to replace her blood. I think that's really it for ATI as far as what you need to know. While we're in this first and second stage of labor, obviously we're checking those vital signs per policy, monitoring the fetal heart rate. And if the baby is really difficult to trace on the monitor, we may insert an electronic monitor into the baby's scalp. It's called a fetal scalp electrode, and it gives us a continuous reading of baby's heart rate instead of a broken strip with the ultrasound. Monitoring those contractions, the frequency, the duration, the intensity, and the resting tone of the uterus with contractions. We talked about the need for potential need for an IUPC, which would give us our millimeters of mercury and strength of our contractions. And then we're going to be doing vaginal exams. Now, here's what's important. Vaginal exams should only be done as necessary. Any increase in vaginal exams just for knowing puts the baby and mom at huge increased risk for infection. So we want to avoid unnecessary vaginal exams, especially if mom is ruptured, right? Because of the risk for infection. Okay, I think that's pretty much it. Let's move into the third stage. So delivery of the placenta. So the third stage starts with the birth of the baby and it ends with the delivery of the placenta. Again, we're going to be measuring all of our vital signs every 15 minutes. It's going to be like post-operative, right? Vital signs. And we're going to get APGAR scores on that baby during the third stage. So at 1 minute, we're going to assign an APGAR score. And then at 5 minutes, we're going to assign an APGAR score to the baby while we're in the third stage, which is the delivery of the placenta. The nurse is going to give this mom oxytocin. So she's going to receive probably Pitocin, oxytocin, a full bag bolus to help her uterus contract down, clamp off those blood vessels, and control bleeding. She may also, if she's got a tremendous amount of bleeding or there's any risk for postpartum hemorrhage, receive methylorganovin. So Methergin or Hemabate, which is carbaprost, right? Or even Cervidil, or one of the other oxytocics that's going to cause contraction of the uterus to help control blood loss. We're also going to administer pain meds to mom, right? If we have to, after the delivery of the placenta, perform any type of stitching up, right? So like, let's say mom had an episiotomy or mom tore, there may be some stitching that the doctor's doing. She might get some lidocaine for that. We're going to clean her bottom after delivery of the placenta, put an ice pack on there, a peri pad. We're going to get baby on mom's chest. And we're going to initiate early breastfeeding if possible. Post procedure, so during that fourth stage, it's just stabilization of mom and baby. We need to have maternal vital signs. When we're assessing the fundus and the lochia, so the fundus, the top of the uterus, we want it to be firm and midline and moving down. So maybe right after delivery, it's at like U+2 or UU right at the belly button. That's fine as long as it's midline and it's firm. If the uterus is not firm, it's called boggy, B-O-G-G-Y, boggy. That means squishy. If the uterus is squishy, we're really concerned about postpartum hemorrhage or bleeding because a firm uterus is contracted and those vessels are clamped off. But if we have a boggy or squishy uterus, that means that we're bleeding inside of that uterus and potentially developing big blood clots or even worse, not clotting at all and having a huge loss of blood. So we want to massage that fundus if it is boggy. Right, that's the first intervention, massage that fundus. And then we might administer oxytocin medications as well to help kind of firm it up, even after that initial administration. So I'm assessing that fundus, assessing lochia. Lochia is the bleeding from the vagina post-delivery, postpartum. It should be rubra, which is red, bright red. Eventually that lochia does change in the postpartum period. We'll talk about that later. But right after delivery, it's bright red blood. And it should be a moderate amount of blood, not a huge amount of blood, but a moderate amount of blood. Again, checking every 15 minutes for the first hour, then every half hour for an hour, and then every hour for 4 hours, and then every 4 hours after that. So those post-operative vitals. Let's see. Should be checking the bottom, making sure there's not a ton of swelling or bruising. I might give the mom some Dermaplast spray, some ice packs. I really want mom to get up and go to the restroom. If I check the fundus and the uterus is off to one side or the other, that could be indicative of a full bladder. So a bladder being full can keep that uterus from clamping down and really staying nice and firm, which is really concerning because we don't want a postpartum hemorrhage. Obviously, I'm going to continue to promote maternal newborn bonding, provide a lot of reassurance with like breastfeeding and infant care to mom and all of those things. And I need to teach that client, hey, if you start to see a lot of bleeding or you feel big gush or you've got big blood clots bigger than like an egg, you need to let me know. And we'll check it out because that would be abnormal. So just real quick, let's talk briefly about the types of pain management we can use during these labor stages. So in that first stage, it's usually back pain, leg pain, lower belly pain, right? As we start to dilate and efface and stretch that cervix. And even though that's the pain that we're experiencing, we're really encouraging mom to do things like aromatherapy and breathing techniques and imagery and music and focal points. We're going to create a dim environment that's comfortable for mom to labor with. We may touch mom, back rubs, massage, get her up walking or rocking. There's also effleurage, and effleurage is heavily tested on ATI, and I don't know why, but effleurage is light, gentle, circular stroking of the belly with the fingertips in rhythm with breathing during contractions. So it provides just a little bit of it's basically a mind game. It provides a little bit of a distraction for the brain from the pain that it's experiencing, which kind of goes with that gate control theory of pain, right? Like a TENS unit. If I can overstimulate my brain with one stimulus, then I'm not going to feel the other stimulus, which could be a very painful stimulus like labor. We also may do sacral counter pressure. That's where there's pressure applied to the back with the heel of the hand or the fist, right in that sacral area. And the patient's partner may be able to assist with this when taught how to correctly. We can apply a heat pack or an ice pack. We could do TENS therapy, hydrotherapy, acupressure, obviously getting mom in all kinds of different positions, teaching her pattern breathing and progressive relaxation. She may participate in hypnosis or biofeedback interventions. If mom is breathing too much, like hyperventilating, we need to, make sure that she's breathing into a paper bag, or we're really coaching her through that breathing, or breathing into her cupped hands, because that could be bad for her and baby. She could be blowing off too much of her CO2 and becoming respiratory alkalotic, right? Which would not be good. Okay. I think that's really it as far as pain management in the first stage. As we move into the second stage, obviously we're going to feel lots of pressure and distension in the vagina and the peri area. There may be burning. We call that the ring of fire that she has to push through. She may split, lacerate, tear, ouch, right? And there may be pulling and pressure on all of the pelvic structures, like the round ligaments, your fallopian tubes, your ovaries, your bladder, all of those fun things. So ow, it hurts. And as far as pain management, we may be moving into some actual pharmacological pain management at that point. So potentially giving an opioid medication like butorphanol or nalbuphine, which has a short duration of action. And although it can cause respiratory distress and depression in the neonate, it can help mom feel comfortable, and usually it wears off pretty quickly. So I would encourage you guys to really review the pharmacological interventions that we use in labor. I don't have the time to discuss those with you, but those are on page 79 through 82 in your ATI book. Okay, in that fourth stage of labor, there may be pain with urination due to the vaginal lacerations, etc. And we can use the peri spray for that. Okay, so we talked about baby's response to birth, right? And how we need to take an APGAR score. So the score can range from 0 to 10. You're going to rate them as 0 to 2 for heart rate, a 0 to 2 for respiratory effort, a 0 to 2 for muscle tone, a 0 to 2 for reflex irritability, and a 0 to 2 for color. If there's a low score, that means we have some serious issues and we need to do some resuscitative measures for this baby. But a high score tells us we have a pretty healthy baby, and we're just going to be doing like some routine care, like drying and stimulating and bulb suctioning, those kind of things. So anything 8 or higher is typically normal, 8, 9, 10, with 10 being perfect. And again, we check the score at 1 and 5 minutes of age, and we expect it to go up. So if they were at 8 at birth, they'd be a 9 or a 10 a little bit later, etc. Okay, your nursing assessment of your client. I really don't know if this is necessary. And I really have so much more labor things, or so many more labor things that I want to talk to you about. I'm just going to continue to be assessing the mom and making sure that she has what she needs to be healthy and take care of herself. Okay, let's talk about this. This is really what I wanted to get into, is so some therapeutic procedures, some medical interventions to help with labor and delivery. So obviously I'm going to be monitoring mom, but sometimes mom doesn't go into labor on her own and I have to induce her. Ways that we can induce mom, we may use prostaglandin suppositories. We may give a little bit of oxytocin. We may start an oxytocin protocol on mom. Giving her IV oxytocin or doing some nipple stimulation to trigger the release of endogenous oxytocin. So if mom is post-term, or we've got a prolonged labor because she's not having enough uterine contractions, or we've been ruptured for a really long time without the start of labor, or not enough labor, there's a risk for infection with that. If there's complications like pulmonary disease, hypertension, diabetes, something like that, I might want to go ahead and induce mom. And then if there's infection of the uterus or the placenta, or death or demise of the baby, I would want to go ahead and induce mom to get this baby out. So if I was going to do some cervical ripening prior to induction, I would just want to make sure that she was prepared and educated about that. I would need to have an informed consent for an induction. And then if I use a cervical ripening agent, I need to get baseline fetal heart rate and baseline vitals on mom. Make sure that those are normal and they look good before I give that cervical ripening agent. And cervical ripening agents, as well as oxytocin, can always cause tachysystole or fetal distress. So I want to be watching for those to make sure that I'm not contracting too frequently or forcefully, and that baby is tolerating everything. So another type of cervical ripening agent besides a prostaglandin suppository we might use is meso, so misoprostol. Misoprostol is a tablet. It may be inserted vaginally to help ripen the cervix. It's important that mom voids before we put this in because we don't want her to get up, pee, and then dislodge it, right? And then we would want to, after we've done cervical ripening, either prostaglandin suppository or misoprostol, we'll move into the oxytocin administration typically. So of course, we always have to make sure baby's engaged and actually coming if we're going to give oxytocin. It should be no sooner than 4 hours after the meso or 6 to 12 hours after the prostaglandin gel or a prostaglandin suppository, so a dinoprostone gel or suppository. Whenever I give oxytocin, so when I start it and whenever I change the rate, I have to get mom's blood pressure, pulse, and respirations. So I need to be getting that every half hour anyway, and then also with any change of the dose. Monitoring fetal heart rate, contraction patterns every 15 minutes in the first stage, every 5 minutes in the second stage, and with every change in dose, just to make sure baby is tolerating labor and we're not becoming tachysystolic. If we do become tachysystolic and our uterus is contracting way too much, way too often, we'll go ahead and discontinue the oxytocin. So that is defined, tachysystole is defined as contractions more often than every 2 minutes, or a really big long contraction, like at least 2-minute contraction, with no relaxation of the uterus between the contractions. Again, a reassuring fetal heart rate would look like a baseline of 110 to 160, moderate variability, accelerations, and no decelerations. If you have an abnormal baseline less than 110 or greater than 160, minimal or absent variability, late or prolonged decelerations, we would notify the charge nurse immediately and or the provider. We would want to position the client side lying to help with uteroplacental perfusion, right, because of the crushing of the vena cava. We also would want to give an IV fluid bolus, so run some lactated ringers in, 999 wide open. Give oxygen, usually 8 to 10 liters by a non-rebreather face mask. We may give a medication to stop the contraction. So we're going to stop the oxytocin. We may also give terbutaline, which is a subcutaneous injection to stop contractions. We also would want to continue to monitor the fetal heart rate to make sure that baby is responding or getting a little bit better looking on the monitor with these interventions. And then if I'm not able to get that fetal heart rate back up or fixed, I may have to go back for an emergency C-section. Let's say we don't need to induce mom, but mom's contractions are just not cutting it. We may do what's called augmentation of labor. That's where we stimulate the uterus because the contractions aren't doing it, right? The progress is inadequate. So it's usually typically oxytocin that we're adding, but another thing we may do is the doctor may go in and complete an amniotomy. So if the membranes aren't ruptured yet, the doctor would want to go in and pop those membranes open, which will cause the body to really kick into labor, right? So want to obviously lay mom back for that. We don't want mom sitting straight up because of the potential for cord prolapse. We would want to monitor baby's heart rate. We would want to assess the fluid if we were assisting with an amniotomy. If we do end up popping a cord, we would want to, if it was an acute cord pop and we see baby go down, we want to stick our hand up there, relieve pressure off the cord by pushing against the baby's head, and we'd go back for an emergency C-section. If there was just intermittent disruption of blood flow through the cord, we may start an amnio infusion, where through that IUPC, we run normal saline to kind of add fluid back into the uterus and raise baby up off of the cord. Of course, baby has to be engaged before we break a water. If not, we have a higher risk for complications. Okay, another thing that we might do is a forceps delivery. A forceps assisted delivery consists of using an instrument. It's got two curved spoon-like blades that come together like scissors around the baby's head, and then you pull. And the pulling is called traction. You apply traction. You're only pulling or applying, of course, you're not doing this, the physician is doing this, during contractions. So if mom is pushing, and we can't get this baby out, mom is getting absolutely exhausted, baby is not tolerating the labor, or we've got a really weird position and we need some help, the physician may opt to use forceps to deliver the baby. So obviously we would need to educate mom about forceps. It can be very scary for mom. Get her into that lithotomy position with her legs up in the stirrups, make sure her bladder is empty. And if she can't get up, we're going to cath her to empty her bladder. That's going to help to provide more room for that baby to come down. The baby has to be engaged, obviously, and the membranes have to be ruptured to use forceps. The provider may ask for assistance monitoring that fetal heart rate. So looking at the fetal heart rate before, during, and after is critical. And if there's compression of the cord, like when we're pulling or when the physician is pulling baby, he's like squeezing the cord against baby's head, we may see a drop in that fetal heart rate. So that's something that would require the doctor to remove the forceps and then reapply them, hopefully not pinching the cord this time. When the baby is born, we're going to be looking for bruising and abrasions from the forceps application. We're worried about nerve damage, so we're looking for things like facial palsies, paralysis of part of the face of the baby. And then obviously we're putting these huge instruments into the vagina. So there's a huge potential for vaginal or cervical lacerations, bleeding, and then bladder injury, urethral injury, huge hematoma formation, bleeding into the pelvic soft tissues. And then obviously make sure that your postpartum nurse knows that you use forceps, because the complications are pretty significant with the lacerations of the cervix, the vagina, the peri area, injury to the bladder, facial nerve palsy or bruising on the baby, and even subdural hematoma on the baby, so bleeding beneath the dura. Okay. Vacuum extraction. This is another thing that we might do to help kind of bring baby along. A vacuum assisted birth involves using a cup-like suction device attached to the fetal head. They're going to apply traction with contractions. They're going to pull with contractions to help that baby really come down. And then right before baby is born, we want to take that vacuum cup off baby's head. Now, baby does have to vertex presentation. That means head first, and you have to be fully dilated to use this. You also have to be able to get that head through the pelvis. If the head's not going to come through the pelvis, then me pulling on that baby's head is not going to help. In fact, it can make things worse. And then you also have to be ruptured, right? I'm not going to be able to get suction on the baby's head if there's a bag of fluids between the vacuum and the baby. Again, the physician is the one doing this, but you may be asked to control the pressure or document baby tolerance, to watch the fetal heart rate during this time. There's a huge risk for scalp laceration, subdural hematoma, cephalohematoma, and then lacerations again to mom's cervix, vagina, or peri area. We would only use this if mom was absolutely exhausted and no longer pushing effectively, or the baby was not tolerating labor anymore. We had to get baby out fast. And we don't usually use this with anyone that's not greater than 34 weeks. Again, we'd want to make sure the client knew that we were going to use a vacuum. We would explain the process to the client, make sure that they gave a verbal understanding, consent, put them in that lithotomy position, get that vacuum cup applied, get that fetal heart rate beforehand, make sure the bladder is empty and catheterize if necessary. And then make sure that after we've delivered this baby, the postpartum nurse knows that we did a vacuum delivery and can monitor the baby for issues on the head, right? Caput succedaneum, caput is swelling of the scalp. That's pretty normal. It goes away in 3 to 5 days, but a subdural hematoma would be less normal and more concerning. Okay. Another thing that we might see with vacuums or forceps delivery are those lacerations. Lacerations are tears, right? And they are classified. So you have first degree, second degree, third degree, and fourth degree lacerations. A first degree goes through the skin, but doesn't involve any muscle. So it's skin only. A second degree goes through the skin and the muscles, but does not go into the anus, right? A third degree goes through the skin, the muscles, the entire peri area into the anus itself. So the external anal sphincter, the outside portion of the anus. And then a fourth degree laceration would tear through the skin, the muscles, the entire muscle body area, and then through the entire rectal wall. So that is a very, very bad laceration. And those are tears again. Those can happen naturally with the delivery of a baby, but they're more likely to happen with a instrumental delivery, like a forceps delivery or vacuum extraction. The doctor may also realize, wait, we don't have enough room for this baby to be born, and proactively cut an episiotomy. Now, an episiotomy is an incision we cut into the peri area to make that vagina larger, so that way we can pull the baby through without hopefully tearing. The idea is that an incision heals better than a tear, right? So if you have a well-approximated wound, it's going to heal better. So let's just go ahead and cut it because I know you're going to end up tearing anyway, or I know this is going to be a difficult delivery. If we're going to do a vacuum assisted or a forceps delivery, we're definitely probably already have cut an episiotomy or will cut an episiotomy to make it easier. So if you've got a big old baby, you could probably just expect an episiotomy. There's two different types of episiotomy that are commonly used. There's a median or midline episiotomy. That's where they cut straight down towards the rectum. It's super easily repaired. It's generally the least painful of the episiotomy types. And but unfortunately, because of the location of the cut, it could extend, as you push that baby, it could extend and tear into a third or fourth degree laceration, even though you cut it as an episiotomy, or the doctor cut it as an episiotomy. Another type of episiotomy is a mediolateral episiotomy. It extends from the vaginal outlet posterolateral, so to the left or to the right. And the goal there is that you don't tear through that rectal wall, right? So even though you might end up with a third degree, because it is lateral, you typically don't end up with a fourth degree. However, it's harder to repair these. They're typically a lot more painful and you lose a lot more blood, but you've minimized the complications associated with typical fourth degree lacerations. So just something to think about. The last medical intervention we're going to talk about for delivery of the baby is cesarean delivery. And this is the delivery of the fetus through a transabdominal incision of the uterus to make sure that baby and client are healthy, especially if there's a type of complication. So there's vertical and horizontal incisions into the uterus. And then, but we obviously like horizontal the best. So side to side the best over vertical. If the baby is not presenting well, so if it's a breech presentation, booty down or feet down, right? If baby's head and mom's pelvis are incompatible, there's a cephalopelvic disproportion. If baby is just absolutely not tolerating delivery or labor and has had recurrent late decelerations or prolonged late decelerations, that would be an issue. If there was an abnormality of the placenta, like a filamentous insertion or vasa previa, or the placenta had started to pull away from the wall, so an eruptio placentae or a placental abruption. Obviously, if we have a previa where it's covering the cervix, we don't want to bleed out from that and potentially lose baby in the process. If it's a high-risk pregnancy, like you're HIV positive with your counts above 1,000, or you have a hypertensive disorder like preeclampsia or eclampsia, if you're diabetic, or have active herpes lesions that could potentially transfer to baby, those might be reasons for a C-section. Additionally, if you've tried to deliver vaginally and you're not getting anywhere, you've had a stall in the labor or some type of baby's getting stuck, that's called a dystocia. We may go ahead and do a C-section. If you've had other C-sections in the past, they may want to just go in and do a C-section. Multiple gestation, so twins, triplets, etc. Umbilical cord prolapse is always a C-section. Any type of congenital malformation or birth defect, it may be a good idea to go ahead and just get that baby out by C-section. And then if mom has heart or lung disease and will not tolerate a traditional labor, C-section makes the most sense. So those are your indications or uses for C-section when you would do a C-section. So before the C-section, it's important to get a good baseline fetal heart rate, vital signs on mom. We put a catheter in mom, a Foley cath. We make sure mom signed the consent. We put SCDs on to prevent blood clots afterwards. We make sure that mom has had any pre-operative medications like antibiotics, medication to decrease the acid in her stomach, those kind of things. We would want to go ahead and get the surgical site prepped with maybe a chlorhexidine scrub, put in an IV catheter, get some IV fluids pumping, make sure that the client has been NPO. They've not had anything since midnight before, the night before. And we want to get the client involved and make sure, or the client spouse involved and make sure that the client spouse and family are all aware of what the process is going to look like. Obviously, there are a lot of complications associated with a cesarean section. Aspiration for mom, she could, inhale her secretions. She could develop an amniotic fluid embolism, which could be deadly. Her wound could become infected or bust open. That's called dehiscing after her C-section. She may have severe abdominal pain, blood clots that move throughout her body, infection at her IV site, hemorrhage. Remember, 1,000 milliliters for C-section is a hemorrhage. She might develop a UTI or have injury to her bladder or bowel due to working inside the abdomen, and she may have potential anesthesia-associated complications. With baby, we might end up taking baby too soon or potentially causing injuries to the baby during the C-section. Those are potentials. Sometimes we do what's called a VBAC. That's a vaginal birth after cesarean. So in order to be eligible for a VBAC, the client would have to have no other uterine scars. No, obviously, you've never had a rupture of their uterus. They would only have to have 1 or 2 low transverse C-section births. Anything else would be a contraindication. The pelvis must be adequate, and as long as there was a non-recurring event, so something that we don't expect to happen again, we can go ahead and do a VBAC. So like a dysfunctional labor or breech presentation or abnormal heart rate, those would be reasons why we did the C-section initially. This would be a candidate for VBAC with the next pregnancy. Okay. I think we're good. Obviously, you couldn't have a VBAC if you had a really big baby or it wasn't presenting well, or you have a head pelvis disproportion, or you've had a vertical incision at any point in time into that uterus. Okay. My slides aren't moving. I'm sorry. Let's see if I can figure it out. Oh, it's because I'm done. Well, let me just tell you guys a couple other things. I want to tell you about some complications we might have during labor before we jump into postpartum. So one of them we've already talked about, that's a prolapsed umbilical cord. So that happens when the umbilical cord gets displaced and it gets caught between the head and the cervix, or maybe even is coming through the cervix. So there's cord compression. We'll see really deep variables, lates, prolonged decelerations. Baby is not getting blood flow. It's like a kinked water hose. So obviously rupturing membranes is a huge risk factor for that. Abnormal fetal presentation is a risk factor for that. They may kick the umbilical cord through the cervix if they are a breech presentation. We also, if the baby is side to side instead of up and down, so transverse instead of vertex, we may see that the presenting part doesn't engage, so that cord goes down into the cervix. If the baby is really small or has a really long umbilical cord, if you've got twins or triplets, if the baby is unengaged or you have a ton of fluid in the uterus, so polyhydramnios, those are risk factors for developing a prolapsed umbilical cord. So what would you see if you, first of all, your client may report it. They'd be like, I think something's coming out of my vagina, right? That would be concerning. We would need to look and see if it's a baby or if it's this cord, right? And then when we are palpating, we may actually be able to feel the umbilical cord. It'll be fleshy. It will be pulsing. And our fetal heart rate monitoring would show variable or prolonged decels. Baby may have baby moving a lot, right? Which means that it is basically suffocating. So we got to get it some oxygen. So you would call for help immediately. So first thing you do, help, help, it's an emergency. Then you would make sure somebody called the doctor. And then with your sterile gloved hand, you would put your 2 fingers into the vagina and push on the presenting part. So the head, the foot, the butt, whatever's right there by the cervix. And you're going to push it up off of the cord. We're going to drop mom into a knee to chest position in Trendelenburg, right? So we're going to work with gravity to get baby up off that cord. We're going to put a warm, sterile saline towel on the cord on the outside to keep it from drying out so that blood can keep pumping through it. We'll keep continuously monitoring the fetal heart rate, looking for signs of fetal asphyxia or hypoxia. We're going to give 10 milliliters per minute non-rebreather face mask oxygen. We're going to start a bolus, right, on the fluid, the lactated ringers, running it wide open. And if we're fully dilated, we need to go ahead and reduce that cord, or the doctor will go ahead and reduce that cord and try to deliver that baby. And if not, this is an emergency C-section to the OR. Obviously we need to be like, it's okay, or well, I guess we shouldn't say it's okay, but hey, you're in good hands, we're working on you, we know what's happening, we're doing everything we can to support you, those kind of things to reassure mom and family. So that's one complication you might see. Another is that meconium stained amniotic fluid that we talked about. So instead of being that clear, maybe light yellow, it's green, black, dark yellow, brown. That's meconium stained. It may even be thick with chunks of baby poop. Remember, meconium is baby poop. So the reason there's baby poop in the amniotic fluid is because that baby was stressed out at some point in time. Obviously, there's an increased incidence for meconium after 38 weeks gestation because the baby is ready to be born. It's mature. And so its body is kicking into, what am I doing? And pooping is one of those things that baby's going to be doing. So we need to make sure that we look at the fluid when we have a rupture. We make sure that if it does have meconium in it, that we've called for respiratory assistance because there may be issues with fetal hypoxia. Or respiratory distress, right? So if we are seeing stained fluid and we've got variable or late decels, that baby is very, very unhappy and we need to get this baby out emergently. I think that's really it for your ATI book. Labor, that's chapter 10. I'm not going to go back into chapter 11 in detail, but please review Leopold maneuvers, fetal heart rate categorization, and your veal chop. Variable decels cause cord compression or caused by cord compression. Early decels are caused by head compression. Accelerations mean baby's got good oxygen. Late decelerations means that there's uteroplacental insufficiency. So placental insufficiency, right? Familiarize yourself with a normal baseline, 110 to 160. Anything below 110 is fetal bradycardia. Anything above 160 is fetal tachycardia. Know why you might see those particular fetal heart rates or patterns. All of that information is in chapter 11. So for example, with fetal bradycardia, if you've got uteroplacental insufficiency, cord prolapse, maternal hypotension, prolonged cord compression, fetal congenital heart issues, anesthesia on board, a viral infection, mom's sugar is low, baby's in heart failure, mom is really cold, you might see bradycardia. So you need to know those things and then not just know what causes them, but how would you respond? So for example, with fetal bradycardia, you would want to correct the underlying cause, discontinue the oxytocin, lay mom on side lying on that left side, give her 10 liters per minute non-rebreather oxygen, get her fluid bolus going, and notify the doctor immediately, and potentially even give a tocolytic like terbutaline. But again, all that information is in chapter 11. Please review it. It's very short, but it gives you a nice summary of fetal monitoring and assessment. Okay, that is it for labor and delivery. I hope that this was helpful. And my next PowerPoint will be over the postpartum period.